This is a continuation of week 6 presentation on musculoskeletal system disorders, and actually I'm picking up where I left off in class on Paget's disease. If you recall from the National Institute of Senior Health video clip that was presented, although Paget's disease is considered relatively rare, it is the second most common musculoskeletal disorder following osteoarthritis. Osteoporosis. Yes, that's a major correction there. Osteoporosis. Anyway, Paget's disease is a scenario where the proliferation of bone destruction initially is extreme and eventually is compensated by the proliferation of bone formation. So we actually have an overgrowth of bone. However, that bone is not as strong as normal bone is, and it is much more vascular in nature. We can see from the diagram here that the bones that are most often involved include the pelvis, the leg bones, the skull, and of course the spine. The onset is insidious. It does most often occur in men older than the age of 40. Many of the individuals with Paget's disease have at least one relative with the disease as well, so perhaps there is some sort of genetic predisposition. The initial clinical symptoms of Paget's disease may be bone pain that develops to irretractable bone pain and fatigue. There is also perhaps a report of a change in skull size. As we saw in the video, the gentleman couldn't wear his hat anymore because his head had grown so large. There could be a change in gait that becomes noticeable, and often individual patients who have Paget's disease of the spine, hips, pelvis, etc. will report that one leg might be getting shorter. Okay. This next slide shows a very exaggerated example of Paget's disease of the skull. And if you can imagine, the individual with that bone pain has increased pressure within that skull on the organs and the nerves that are within the skull. So the people with enlarged skulls tend to report headaches, visual disturbances. They may experience dementia-like symptoms, problems with hearing. And again, the bone pain itself is typically not relieved with rest or activity. Even the lab tests that can help diagnose Paget's disease include elevated serum alkaline phosphate levels, and again, we're using bone scans and X-rays to help diagnose Paget's. The emphasis nursing management, as with many of our disease processes, includes education, making sure the individuals are aware about treatment and how to manage pain. We want to make sure that we address any safety and mobility issues that may cause problems as a result of visual defects or hearing impairment as a result, or gait impairments could be related to safety and mobility issues. We want to make sure that we pull in the appropriate therapists, for example, physical or occupational therapy, to help individuals maintain optimal functioning. We want to consider the correction of any deformities if necessary with the use of braces or surgery. And human calcitonin has been shown to provide some relief with the increased activity of the osteoclasts that's associated with Paget's disease. It also can be positive in terms of limiting bone resorption, and it'll also lower the serum alkaline phosphatase. So human calcitonin is an appropriate method of treatment for consideration as well. Care of the Paget's disease, again, it's usually limited to symptomatic and supportive care, uh, correcting the deformities by surgery or braces, and again, relief of pain. Individuals with Paget's disease, we want to encourage them to use firm mattresses for back support if they've got spinal involvement, perhaps a good use of a back brace, good body mechanics, and again, making sure that their diet is appropriately supplemented with vitamin D, calcium, and protein, which are all necessary for the formation of healthy bone. The next major musculoskeletal problem I wanted to address is osteomyelitis, which is an infection of the bone marrow, and or the surrounding soft tissue. Osteomyelitis is very often caused by Staphylococcus aureus. It's one of the most common bacteria related to this problem. And you can have acute osteomyelitis or chronic. Acute osteomyelitis is usually treated with antibiotics, and it will resolve within approximately 4 weeks. And chronic osteomyelitis lasts longer than that and fails to respond to initial antibiotic therapy. We often see manifestation of osteomyelitis in older adults as a complication of stage 4 pressure ulcers. These individuals may have subtle changes in their mental status. They may have low grade fever and present with an increased purulent wound drainage as indicators of this particular disease process. Unfortunately, oftentimes, again, with the older adult who presents atypically with many disease processes, the signs and symptoms of osteomyelitis may go unnoticed until sepsis occurs, and then we're often in trouble. But however, important to note that when treated early, osteomyelitis has a very good prognosis. This next slide addresses several of the different organisms commonly associated with osteomyelitis. Again, Staph aureus being the number one associated organism with osteomyelitis. But it'll show you the organism and some of the possible problems that might be presented with this particular disease process. The infecting organisms from osteomyelitis can invade the individual by either indirect or direct entry. Here we're looking at the indirect entry of microorganisms, and it most frequently affects the growing bones in boys who are less than 12 years of age, and is associated with their increased incidence of blunt trauma for the particular population. And the most common sites of indirect entry in children are the arms and the legs. Adults also who have are at increased risk for indirect entry of osteomyelitis if they have vascular insufficiency disorders, for example, with diabetes mellitus, any GU or respiratory infections. These individuals are at higher risk for a primary infection to spread via the blood to the bone. The most common sites of osteomyelitis infection in the adult are the vascular rich bone sites, including the pelvis, the tibia, and the vertebrae. Osteomyelitis through direct entry into the body can occur in individuals at any age where there's an open wound where microorganisms can gain entry into the body. It can also occur in individuals who have the presence of a foreign body implanted, for example, implants, knee replacements, elbow replacements, hip replacements, etc., and other orthopedic or prosthetic devices, pins and rods, etc. Well, after the microorganism enters the body, the organisms lodge in an area of bone, and in this area, the circulation actually starts to slow down, and the microorganisms proliferate and begin to grow. This typically causes an increase in pressure because bone is typically non-expandable, and it results in surrounding ischemia and vascular compromise to that part of the bone. Eventually, something called a sequestra develops where the infected part of the bone breaks off and kind of isolates itself, kind of like an island, and it actually makes this part of the infected bone very difficult to be treated with antibiotics because it has, once again, it's kind of isolated itself from the rest of the bone. So what happens to this sequestra, it tends to enlarge and serves as a site for the microorganisms to spread to other parts of the body via the bloodstream, including perhaps the lungs and the brain. Remember, our older adults don't typically show the classic signs of infection, and the first sign of osteomyelitis could perhaps be sepsis, and at this case, in this scenario, of course, they would be a poor prognosis. Once outside the bone, the sequestrum may actually revascularize and resolve through normal immune process, or it might need to be surgically removed through debridement of the necrotic bone itself. However, if the necrotic sequestrum is not resolved and removed, it will end up developing a tunneling and a sinus tract, which results in chronic, purulent, and cutaneous drainage. So clinically, again, we talked about acute and chronic osteomyelitis. Acute being osteomyelitis that's treated and resolves within 1 month or less in duration. And some of the clinical manifestations of acute osteomyelitis include both systemic and local symptoms. Systemic manifestations may include fever, night sweats, and chills, maybe nausea and some malaise. And then local manifestations include the constant bone pain that is not relieved by rest and actually worsens with activity. There's actually some swelling that goes on, tenderness and warmth at the site of infection, as you can see by some of like this slide and the previous slides. And there's going to definitely be restricted movement in the area as a result of pain. Again, later on, we're going to see drainage from sinus tracts that develop to the outside of the skin, and perhaps at the fracture site as well, if it involves a fracture. And of course, the chronic osteomyelitis doesn't resolve within a month or so. It has failed to respond to the initial course of antibiotic therapy, and systemic signs and symptoms may have subsided by that point. And again, the more overt clinical manifestations are going to be at the site of infection, including constant bone pain, swelling, tenderness, warmth at the site, and most likely the development of sinus tracts and purulent drainage. Some of the diagnostic tools that we can use to diagnose osteomyelitis include the bone or soft tissue biopsy, which will isolate the organism for us so that we can better target our antibiotic therapy. We can culture the wound itself or the patient's blood, and again, determine what the organism is. Radiologic signs don't typically appear in regular x-rays until almost 2 weeks into the start of the presentation of clinical symptoms. So better diagnostic tools than regular x-rays would be radionuclide bone scans involving gallium and or indium, and they're very useful in identifying the infection, including some of the soft tissue involvement. Also very commonly used to diagnose osteomyelitis and the extent of the infection to the bone would be MRIs and CAT scans. Nursing management is going to evolve around management of pain. We're going to most likely need to assist the patient in immobilizing the affected extremity. That's going to need to be done probably because of pain and because of the risk for spontaneous fracture as a result of bone impairment and deformity at this point in time. So immobilization of the involved extremity, helping monitor and treat pain. We're going to, of course, ensure that our patients follow through with any parenteral IV antibiotic therapy that's ordered, and encourage them to follow through with oral antibiotics if they are sent home to continue on oral antibiotic therapy. Surgical treatment for unresolved chronic osteomyelitis may be indicated. It involves the removal of the dead bone and surrounding poorly vascularized tissue that's been damaged by the infection process. It also is going to involve extended use of parenteral antibiotics. Surgically, they may implant antibiotic impregnated beads to help resolve inflammation and infection at the site itself. Bone grafts may be indicated to help restore bone flow to damaged bone, and amputation if the destruction of the bone has gone beyond potential repair. So post-operatively, with any of these surgical treatments, we're going to, of course, maintain strict sterile technique, monitor for further signs of infection, and treat the patient for pain management, and get that extremity healed and back in use as quickly as possible. Okay, I've got a short case study. We have a 74-year-old male is brought into the clinic by his daughter, and he's complaining of a fever, nausea, and pain in his left leg. He lives alone, has poor hygiene. He's very infrequently gone for medical checkups over the past years. He's a diabetic, and he's got a history of foot ulcers. Again, poor hygiene. You observe noted inflammation in his left lower leg, and the individual presents with guarding of the left leg. He's got restricted movement, and it appears painful, and he stated it is painful. The gentleman is admitted to the hospital, and his lab values, not remarkably so, indicate an elevated white blood cell count, and a CAT scan of the leg indicates severe inflammation of the tibia and the surrounding soft tissue. So, the daughter wants to know how her dad's bone could get an infection. So, take a minute and answer, how can the nurse explain the disease process and the likely cause? Why would it be important to receive IV instead of oral antibiotics? Number 3, what crucial teaching must be done before the patient is discharged? And what resources might be helpful for this individual in the home setting? So going back to the first question, how can the nurse explain the disease process and the likely causes to the daughter and to the patient? Well, this individual has diabetes mellitus. He's got a history of poor hygiene and foot ulcers. So to me, that's a clear indication of a direct entry route for a microorganism to enter the bloodstream through the foot ulcer wound and enter into the bone and develop into osteomyelitis. Um, why is it going to be important for this particular patient to receive IV instead of oral antibiotics? Well, it looks like the infection is serious. It has been going on for a while, and he's going to need some intensive IV antibiotic therapy. What kind of teaching must be done before the patient is discharged? Well, number one, how important it is going to be to improve the hygiene and keep that infected area clean. We're also going to need to educate the patient and the daughter on the importance of following through with the prescribed antibiotic therapy while at home, not to stop taking the antibiotic until all the medication has been taken, and how to observe for any further signs or symptoms of signs of infection. The resources that might be helpful for this individual at home might be a home health nurse to help monitor the antibiotic therapy and to make sure that the individual is being assessed periodically to ensure that he is in fact responding to the antibiotic treatment. Okay, ends my discussion on osteomyelitis. Again, read your Lewis text that my slides correspond to. If you have any questions, please bring them to my attention. I'd like to talk now about degenerative disc disease. It's a structural degeneration of the lumbar and cervical discs predominantly. The slide here shows you what a normal disc looks like. It shows you what a degenerated disc will look like: a bulging disc, a herniated disc, a thinning disc, and a disc with osteophyte formation. DJD, or degenerative disc disease, it's progressive. It is typically considered a normal part of aging. As a result of wear and tear on the vertebrae, the center of the disc starts to dry out and shrink, leading to less space in between the vertebrae themselves and a potential for loss of elasticity, less shock absorption, and of course a decrease in the flexibility. An example of a herniated intervertebral disc is shown here. If you look on this all the way to the right side of the slide, you'll see where the line points to the disc, how it protrudes into the spinal canal, pressing on nerves, causing discomfort. It's also called a slipped disc. Again, it can be a result of a natural degeneration of the disc itself with age. It can also be a result of stress and trauma to the spine. Again, the biggest problem here is pain, decrease in function as a result of the pain, and pressure on the nearby nerves. The most common sites of herniated intervertebral discs are the L4, L5, and S1 locations. This slide shows you how herniated disc pain can very often run down the sciatic nerve and radiate from down the buttock and below the knee along the sciatic nerve. That's a very common type of pain associated with herniated discs. Normal deep tendon reflexes may be absent or depressed with this type of disc pain, and the RN needs to educate the patient who experiences paresthesia type pain, intermittent claudication, muscle weakness in the legs, feet, or toes to report this type of pain to the healthcare provider so that we can evaluate the extent of the nerve damage and relieve the pressure on the nerves if at all possible. Okay. So this slide shows you, we start talking about surgical repair. To remove the part of the vertebrae or the lamina to gain access to the disc that's damaged so that it can be removed. And if you notice on the right hand side of the slide, it looks like metal coins or metal discs can be inserted in place of the normal disc that has become impaired as a result of trauma or age or whatever. So the laminectomy is the procedure. It's the most common one, surgical procedure. And post-surgical repair of a lamina is the nurse's responsibility to make sure that, again, good body alignment is maintained after surgery. Individuals after spinal surgery need to be log rolled to maintain the integrity of the vertical alignment of the spine. The entire body is turned as a unit to prevent post-operative misalignment of the spine. Um, Before surgical therapy, however, of course, we're going to try our less invasive therapies. We're going to, initially restrict the spinal movement. We're going to perhaps try heat and ice. We may use massage. We may apply ultrasound therapy to the areas of discomfort. We might try traction. We may use the TENS unit again, which is the transcutaneous electrical nerve stimulation device. You'll see that used quite often at the rehab hospital and as a form of alternative treatment. Other individuals may choose to use acupuncture. We're, of course, asking our patients to take short term opioids, perhaps muscle relaxants. They may be on NSAIDs. Anyway, all of these other conservative methods of treatment, if they're not effective, then of course we're going to result to the surgical removal of the disc itself. Ankylosing spondylitis is a rheumatic disease, and it typically occurs during young adulthood. It is a chronic and inflammatory disease of the axial skeleton. And the axial skeleton, just a reminder, consists of the skull, the rib cage, and the vertebral column. So it's an upper body inflammatory disease of the skeleton. The joints and the intervertebral disc spaces tend to become fused together, as you can see on the slide picture all the way to the right in the circle, and it results in a chronic low back pain, severe stiffness, and severe limitation of movement. The stiffness and discomfort typically is worse at night and in the morning, again after periods of inactivity, and will often improve with some mild activity. In women, some of the signs and symptoms may occur more often in the neck as opposed to the lower back. Very rarely with ankylosing spondylitis will there be any generalized symptoms. It's more typically located locally at the site of impairment. So the next slide here we have a photo of a gentleman with severe ankylosing spondylitis. That's what it looks like clinically. A fixed kyphotic posture, head bent down, resulting in altered visual functioning, resulting then in perhaps some safety issues regarding ambulation that might need to be addressed. The constant kyphotic posture is going to result in perhaps some aortic and cardiac insufficiencies, some pulmonary related issues as a result of the inability to fully expand the chest and lungs. So he's got impaired range of motion. Typically, this onset occurs early and in young adulthood, ages 25 to 34 years of age, and in 80 to 90% of these cases, the HLA antigen genetic complex is present, so that is a good indicator of diagnosis of ankylosing spondylitis. Prevention's not possible, so early detection and treatment is going to be important here. We want to focus on maintaining skeletal mobility through exercise and movement. We want to focus on decreasing pain and inflammation through the use of heat and cold, NSAIDs, aspirin, and DMARDs, as this is a rheumatoid type disease. Local corticosteroid injections into the vertebral column can be helpful as well. And hydrotherapy is, of course, a good method to help increase motion to the affected skeletal joints. So the patient with ankylosing spondylitis should be encouraged to do stretching and strengthening exercises, again, to keep mobility as a factor. The individual should avoid prolonged standing and walking. Good body mechanics, proper positioning at rest is very important again. Good body alignment, lying flat on the back, avoiding any positions that encourage flexion and deformity. You want to encourage deep breathing exercises to encourage chest expansion, and encourage anyone who smokes and has ankylosing spondylitis, of course, to stop smoking. The next disease I'd like to talk about is systemic lupus erythematosus. Um, it is a very complex disease of multifactorial origins, including genetics, hormones, the environment, and immunologic factors. It can affect the skin and the joints. It can affect the pleura of the lungs and the pericardium, our kidneys, our blood system, and neurologic systems as well. Its prevalence is from 2 to 8 cases per 100,000 in the United States, most commonly in women of childbearing years and in women overall more than men. This particular disease is more prevalent in African Americans, Asians, Hispanics, and Native Americans when compared to their Caucasian counterpart. There are periods of exacerbations and remissions, and there is typically no predictable course for this particular disease. It involves multiple systems, and it's an inflammatory autoimmune disease of serious consequences. This is the classic telltale butterfly rash that we see over the cheeks and the bridge of the nose. It commonly presents itself in about 50% of the individuals who are affected with systemic lupus. Lupus is characterized by the production of a large variety of autoantibodies that attack single and double-stranded DNA. All right, and the autoimmune reaction characteristically is directed against the nucleus of the cells, particularly the DNA cells. And how systemic lupus presents itself or manifests itself is certainly going to depend upon which cells and which organs are involved. You can see on this next slide some of the different locations where systemic lupus can present itself on the skin. The cutaneous lesions, which are actually quite vascular, they can appear in any location, but they're more likely to develop in areas that are exposed to the sun. Again, the circulating immune complexes that contain the antibodies against the DNA, these complexes are deposited in the capillaries of multiple organs within the body, including the heart, the kidneys, the skin, the brain, and the joints. And from there, that's where the process of the inflammation actually begins. This diagram is taken out of your Lewis text on page 1665. I think it gives you a very clear and alarming indication of how severe and profuse this particular disease process can actually be. Again, symptoms it can be range from very mild in its onset and disease process to very rapidly being very rapid and progressive, affecting many or all of the body systems that are depicted here. The most commonly affected tissues are the skin and the muscle linings of the heart and the lungs, as well as the nerve tissues and the kidneys as well. Before I start addressing the interventions for lupus, I just want to go back a minute to the etiology of the disease. Again, it's an abnormal immune response, and we're not quite sure where this or why this response manifests itself in certain individuals. There is a suspected genetic component with the presence of genes from the HLA complex being present in many individuals with lupus. We know that hormones play a factor. The onset of menarche, the use of oral contraceptives, and both during and after pregnancy presents a heightened clinical manifestation of lupus in those females who develop it. And we know that sun and sunburn are the most common environmental triggers for lupus. Individuals with lupus need to understand that even even though they're following their treatment plan rigorously and valiantly, they need to realize that there is no guarantee against the exacerbation of their illness. And that's because the course of the disease, like we've said before, is unpredictable. There are a variety of factors that tend to increase the disease activity. This can include excessive fatigue, again, exposure to the sun, emotional stress, infection going on elsewhere in the body, and certain drugs can also precipitate the onset of lupus. These drugs include pronestil, apresilene, and a number of anti-seizure medications can, again, result in the clinical manifestation of lupus. So treating lupus, again, the treatment is as variable as the disease itself. Typically, NSAIDs are a very important intervention in the management of lupus, especially with individuals who have pain in multiple joints. Also, because of the NSAIDs, you want to make sure that you're monitoring for the potential GI effects. The use of anti-malarial agents is often used to treat the fatigue as well as some of the skin and joint problems. High doses of corticosteroids and immunosuppressant drugs can be used in severe cases. Remember that prevention is not possible, so early detection and treatment of the disease, of the specific clinical manifestations for that individual is the most important part of what we can teach our patients. We also want to make sure that we're providing appropriate emotional support. Individuals are concerned about passing this disease on to their family members because of the probable genetic component. Individuals who experience some of the overt skin disfigurements are going to be affected by their body image, and self-esteem will be affected as well. So being aware of the need for emotional support is very important for the nurse in caring for patients with systemic lupus. Again, I just want to focus that there are there is a list of criteria for the diagnosis of systemic lupus present in the book. That would be table 65-14 on page 1666. Please don't feel the need to memorize that. Just be aware that there is a list of specific criteria that is helpful to diagnosticians when there's such a myriad of clinical manifestations and symptoms that present themselves with lupus. So you've got that list, and also there are two very important diagnostic tests that are pretty well used to confirm, along with the presence of the symptoms, to confirm lupus. One is the anti-Smith antibody test, and the other is called the anti-double-stranded DNA test. And these are very useful diagnostic tools when trying to diagnose lupus. So some important things for the nurse also to remember: to teach the patients the importance of using sunscreen, as very severe skin reactions can occur in patients with lupus who are exposed to the sun. So using sunscreen, avoiding excessive sun exposure is very important. Avoid excessive fatigue. Incorporate periods of rest in the daily activity as much as needed, and reminders that oral contraceptives can in fact exacerbate systemic lupus. Okay. It's the last disease I'd like to address today is fibromyalgia. It is not degenerative, it is not progressive, and it is not an inflammatory process. It is a very commonly diagnosed musculoskeletal disorder, and it is a major cause of disability in 2 to 5% of the United States population. It's more common in women than men, and it typically manifests itself with multiple tender points throughout the body. Sleep that is non-restorative. People wake up and they feel like they have not rested at all. Widespread burning, bilateral musculoskeletal pain, a wide range of cognitive defects. Paresthesias of the hands and feet are common, as well as restless leg syndrome. This slide gives you a picture of the tender points that are associated with fibromyalgia syndrome. And again, diagnosis of fibromyalgia syndrome would involve the presence of pain in at least 11 of the 18 identified tender points on palpation. So you can imagine, if you had pain and tenderness in 11 of those spots, you're going to have pain and tenderness in a large percentage of your body. So individuals report widespread pain, bilateral, both above and below the waist, and it needs to be present for 3 or more months for a confirmed diagnosis of fibromyalgia. Nursing management of fibromyalgia includes educating the patient to incorporate periods of rest in their daily routine as necessary, the use of over-the-counter analgesics to relieve some of the discomfort in the tender points. Muscle relaxants may help with the improvement of nighttime rest that we hope would result in restorative rest, and the importance of the role of the RN as a support person. Relaxation strategies to relieve stress, especially in preparation for sleep, is also important in fibromyalgia. Okay, one last slide before I'm finished, and it has to do with feet. my major emphasis here is you can't do a full physical assessment on an individual unless you assess their feet as well. We've been talking about all these musculoskeletal problems over the past two lecture periods, and we can't ignore the important role that our feet play in our ability to be mobile. Typically, in the head to toe assessment that's done in the hospital setting, you're going to assess pedal pulses. Well, do a little bit more than that. Take a look at the feet on the patients that you're caring for. Ask your patients if they have any problems with their feet, if their shoes fit well, if they have any discomfort related to the hypertrophied nails that you often see in the older adults, or the protruding bunions on the side of the foot as a result of poor fitting shoes or perhaps just some congenital deformities. Um, Ask your patients about their feet, how they're how they're holding up, or how they are interfering with their ability to do some of their activities of daily living, and be a troubleshooter. Make a reference or make sure the primary physician is, you bring to the attention of the primary care provider some of the problems that the individual is having so that referrals can be made appropriately while the individual is within your care. That ends my presentation on musculoskeletal issues. Again, please make sure that you address any questions that you have so that I may assist you further.